Good afternoon, everyone, and welcome back to our first Nursing Home Leadership Roundtable of 2023, hosted by Superior Health Quality Alliance. It's really great to see so many new names and faces on our call, so we're really glad you're here. If you joined us throughout 2022, welcome back. We're glad to have you. So my name is Kelsey Ostergren, and I am joined by my program co-leads Jerry Hinneker and Kim Haft. And we are really excited today to be joined by Karen Jones from the University of Michigan to share a little bit about antibiotic stewardship in long-term care, some best practices and updates. And this topic actually was a topic that was suggested from our audience, from you guys. So thank you for that. And if there are other topics that you're interested in us covering, please let us know. Send us a chat, send us an email. We're always open to any feedback and suggestions because we really want this time to be meaningful to you for whatever challenges you're dealing with or trying to navigate. So again, if there are other topics that you think would be beneficial either for you or for a larger group, please let us know, and we're happy to cover those in a future session. Just a brief reminder as we are entering our 2023 session, for those of you who joined our programming last year, you'll know we had these sessions every single week. In 2023, we will now be doing twice a month sessions. So they will be the second and the fourth Wednesday of the month. So again, just a reminder for those of you who maybe joined us last year that this is a bit of shift in schedule, but we're hoping that by moving to twice a month, that'll allow you guys more time back and a little bit more flexibility with scheduling, and also give us more time and bandwidth to put together presentations that are really meaningful for you. As always, the slides for our presentation will be available, and I see Jerry has just dropped a link to those in chat. And then the other just note here, because I know there are some new folks on the line, at the end of the session, we always ask for your feedback. So we will share a link to an evaluation form. I would appreciate if you could just take a couple minutes to fill that out. It's really, really brief, but it just helps us to make sure that we're hitting the topics and the needs that you have. And if not, please let us know how we can do that better, because that's certainly our goal. The last reminder I will give before I turn the floor over to Karen is that these sessions are intended to be both educational as well as a time for you to connect with your peers as well as with the team at Superior Health. So if there's something you're struggling with, if you have questions, please feel free to use the chat box, unmute yourselves when we get to Q&A. And that time, again, is really intended both to be a Q&A on the presentation, as well as just any other questions you have that you want feedback from a peer facility on how are you handling this, or we're struggling with that. Does anybody have a policy on how to do this? Anything and everything goes. So really just want to encourage you to use this time to connect with one another, connect with us, and ask any questions that you might have. I know that was a whirlwind. Hang in there. We're glad you're here. And Karen, I will turn the floor over to you.
Terrific. Thanks so much, Kelsey, for inviting me to present today. And thanks everybody for joining in. My name is Karen Jones. I am currently a project coordinator at University of Michigan. I've been in this role for almost 5 years. I work with Dr. Lona Modi, who's done a ton of work in the Division of Geriatrics as it relates to infection prevention and epidemiology. So as we go through the slides, I'm going to be peppering in a little bit of the research that we've done, not just our team, but others at University of Michigan and actually other research findings. So I hope you find it interesting. Please, by all means, throw your questions in the chat. If I'm not able to answer your question, I will definitely follow up with you. Next slide. Our objectives are listed here. Just give a very brief overview of infection prevention, antibiotic prescribing trends in nursing homes. Talk about how antibiotic stewardship can actually improve nursing home resident outcomes, and give some actual findings that have been published, and then spend most of the time looking at antibiotic stewardship interventions that apply to nursing home environments. Next slide. So my background is actually, I'm an actually a nurse, and I spent many, many years in the emergency department, got pulled into quality improvement and infection prevention at the hospital level in a big hospital in Detroit, but really wanted to branch out into infection prevention research. So that's how I got to be where I'm at. I recently gave a presentation to the Association for Professionals of Infection Control Great Lakes chapter. So that's the Michigan chapter. And I included this slide because we have infection preventionists actually from all different types of healthcare environments. So still a big focus on acute care, but nursing homes, long-term acute care hospitals, surgery centers, endoscopy departments, things like that. We've got a lot more of individuals that are involved in infection prevention. And what I wanted to do was to give them just some groundwork as things look in nursing homes. So what are some of the nursing home specific additional challenges as it relates to infection control? So definitely not everybody obviously is greater than age 65 or older in nursing homes, but many are. There are additional challenges as we're looking at identifying infections given different signs and symptoms as we age. A fever may not look like a fever of a 20-year-old, somebody that's 90. Effects of older age with immune system changes, environmental level. So nursing homes, skilled nursing facilities, many shared spaces, which are very different from the other healthcare environments that infection prevention is looking at. But one of the big things, and you can advance to the next one, is antibiotic overuse and rise in multi-drug resistant organisms. So that's going to be my focus of the next 55 minutes or so. Next slide. What's the backdrop of antibiotic use in nursing homes? Probably nothing new for you to know about, but antibiotics are among the most prescribed medications in nursing homes. Up to 70% of nursing home residents are receiving at least one antibiotic prescription per year, some more than that. And up to 3/4 of those antibiotics could be improved upon because they're not prescribed correctly. And that covers a multitude of different aspects. That could be the reason why they're prescribed, could be the dose, could be the duration, which is one of the big things that antibiotic stewardship programs are hammering down on, but also the actual drug that's being prescribed, because we know that oftentimes there can be safer choices when it comes to antibiotics. This information, I'm going to have references at the end of this presentation, but some of these basic slides and information can be pulled from the CDC core elements of antibiotic stewardship for nursing homes, which many of you probably are already familiar with. Next slide. I added this slide, and I don't usually like really busy, filled with numbers types of slides, but I thought that this one was particularly interesting because it was a really huge study that was published. What they looked at were facility level antibiotic use trends across the country. There were over 300,000 nursing home residents included in this study, and it covered over 1,600 US nursing homes. Back a little bit further than we'd like to see, but 2016, it still gives some great information. Overall, you'll see the number is 436,619. Those are the total number of antibiotic prescriptions written in 1 year. And you'll see highlighted in with a red box, the most common reason for antibiotics are genitourinary infections. And that's closely followed by respiratory infections. Not a big surprise. And what is the antibiotic that's most often prescribed? Ciprofloxacin for GU infections. And for respiratory, you'll see levofloxacin. And that's kind of an interesting aspect because we know that that's from a class of fluoroquinolones, which I'll talk about a little bit further on. But that's a class of antibiotics that carry with them more than the usual side effects or adverse effects. And one other thing I just want to highlight, if you look all the way over to the right, you'll see course duration. What's the median number of days that a resident is on an antibiotic? You'll see that those are generally around 7 to 8 days. One thing that was found, so over 50% of nursing home residents received a systemic antibiotic, so something that's not like an antibiotic topical cream or something. And there's a high variability among nursing homes. So again, this is a big study that's looking at all these nursing homes across the country that they did notice some interesting trends. So I'll have a link to this at the end of the talk. Next slide. Inappropriate antibiotic prescribing in nursing homes is not a brand new concept or idea or problem. And I mean, beyond that, we know that hospitals have their own sets of issues. Back in 1986, there was one of the biggest and first antibiotic use trends papers published, which looked at over 1,700 nursing home residents. And you can see in the right column, what did they find? What are the percentage of inappropriate antibiotic prescribing incidences were noted? One of the most interesting ones throughout these papers is the one published by Mitchell in 2014, because they looked at patients with advanced dementia in over 20 Boston nursing homes. And I think that's really interesting because those are, I think you probably agree, probably one of the most challenging populations when it comes to determining infections, right? A lot of times they're not able to accurately describe signs or symptoms, and that can make things even more difficult. But overall, obviously some room for improvement when it comes to antibiotic prescribing. Next slide. Risks with antibiotic use, particularly as we age and as we are taking additional other medications, right? It's probably quite unusual that a nursing home resident would only be taking one antibiotic without anything else related to high blood pressure or diabetes or any other chronic conditions. But as the antibiotics, as they start using those antibiotics, especially when it comes to using other medications, the risk for toxicity increases, and that can affect all the different body systems. Allergic reactions are a big concern. As I mentioned, I worked in the emergency department for many years. The number of people coming in, and obviously this expands beyond nursing homes, but with adverse drug reactions are really quite high. And many times those were related to new prescriptions of antibiotics. Medication like Cipro, those have very commonly GI associated adverse effects. So if somebody's coming in with nausea, vomiting, they've got a true infection, they can't keep down the antibiotic, leads to other issues as well. So nothing new, but definitely risks associated with antibiotic use. The biggest one that we'll be talking about are antimicrobial resistance. Next slide. I included this slide just to kind of highlight the 30-day mortality risk involved with invasive or bloodstream infection, antibiotic resistance. And this is looking at hospitalized patients. And in red, the bar indicated in red shows the infections that are acquired in the hospital. So many times hospitalized patients are going to have many other things going on with them, at risk for developing infections. And then once they contract these specific MDROs, there's a much higher risk of mortality within those 30 days. And again, this is for older adults. And you can click the next slide. Just highlighted those. These are some of the bigger ones. Probably nothing new for you. The carbapenem-resistant Acinetobacter, almost 27% of 30-day mortality for hospitalized patients, but also things like Pseudomonas aeruginosa, VRE, CRE, and down the line. Next slide. Candida auris has been in the news. A very resistant yeast infection that can infect any body site. Some people are colonized. Once it becomes an actual clinical infection, it's kind of scary because there are a very limited number of antifungals on the market that can effectively treat Candida auris. So I included this slide just so you're aware of Candida auris. And I know not all of you are from Michigan, but I included this quote down at the bottom. It's from Dr. Natasha Bagdasarian, who I had the pleasure of working with when she was an infectious disease physician in Detroit. She's now the chief medical executive for Michigan Department of Health and Human Services, and she was quoted in this JAMA article from December of 2022 saying, many cases went undetected in 2019, 2020, 2021, when public health laboratories overwhelmed by COVID-19 and chronic underfunding didn't have the bandwidth to look at Candida auris. And I included this because I want really any healthcare facilities, but especially nursing homes, to be aware of what your labs are capable of doing and identifying. Make sure, it's my recommendation, that your lab has the ability to specifically look for Candida auris and has a method of identifying your facility if they do come across one of these. Labs, some are fully aware and have a method of looking at these, but not all. And it's really important that if something like this were to pop up at your facility, that you have a method, a chain to be able to head that off immediately. Next slide. All right, so back to the topic at hand. Prescribing trends may affect the entire facility. This was very interesting to me because this is kind of a side finding from this study, is that even if you yourself, say if you're a nursing home resident, were not prescribed an antibiotic, say within the course of a year, what does that mean for your chances of developing an MDRO in the future? And they found that when the facility has a high antibiotic use rate, that others in the facility, even those that have not been prescribed an antibiotic, have a greater risk down the line of developing an MDRO. So one question to think about. Don't need to type in now, but we'll be circling back at the end of when we have time for Q&A. Do you know your facility's prescribing trends and how that could affect others that don't necessarily need antibiotics during the course of a year? Next slide. Antibiotic stewardship programs for nursing homes, nothing new. Back in 2017, started that up. And I'll have to say, I was working in the hospital, I think it was 2014 when this hit hospitals. There was a lot of scrambling, a lot of confusion. So eventually everybody got things together. We were able to use the electronic medical record to really assist in the development of a strong antibiotic stewardship program. Granted, we had different resources, but that can definitely translate to other facilities. Do you know that there's wide variability when it comes to members of the stewardship program at a facility? Guidelines always refer back to those CDC core elements. Those are very helpful, and the level of engagement within the team. Next slide. All the credit to Dr. Payal Patel, who is an ID physician previously at University of Michigan, very involved with antibiotic stewardship programs. This is her listing of the 3 absolutely key elements. Need to recognize the 5 Ds of antimicrobial stewardship, and those are listed there. Things we already mentioned, the drug route, dose, duration, and then de-escalation. Does somebody necessarily need to be on an antibiotic for 7, 8, 9, 10 days? Measure and improve these, and always adhere to those 5 Ds, because we know that those will affect the MDRO burden, not just of the individual, but of the healthcare facility. Also, C. diff, it's a big one, and then risk of yeast infection in the blood, which is not beyond Candida auris. A yeast infection in the blood can be very devastating. Just a side note, I use antimicrobial stewardship and antibiotic stewardship pretty much interchangeably. The difference, antibiotics are for bacteria, antimicrobials cover bacteria, viruses, fungi, yeast. If anybody was curious to know that. I think probably antimicrobial stewardship is more accurate. Next slide. All right, for those that like conceptual models, I don't necessarily, but I think that this one in particular is kind of helpful when you're having issues getting your antimicrobial stewardship program up and running, or you're running into barriers. You can hit the next slide. I've got some little highlight pop-ups here. So we start here at the clinical situation, which could be anything. And next, click. And we want to get to the prescribing decision. So what are some of those factors that will get us from point A to point B? Next, click. Patient and family factors. What are the patient or resident demographic characteristics and their health status? But also need to bring in the family's perception, knowledge, attitudes, beliefs. That can seriously impact the decision. And then facility and staff factors. I found we work quite a bit with different nursing homes throughout the state of Michigan, and we know that even if the director of nursing or administrator leaves, many times the facility still functions as a facility, and a lot of the same challenges remain. Next, click. And then also provider and practice factors. What are the characteristics and prescribing traits, I guess, of those providers at the facility? Is there 1 or 2 providers that love to prescribe antibiotics quickly without more of a watch and wait method, which is sometimes recommended? Next slide. So some of the recommended strategies, I also refer people back to the AHRQ strategies to reduce potentially inappropriate antibiotic prescribing. It's a really great toolkit. If you haven't taken a look at it, I recommend to. There's a lot of great training resources and different types of modules. What's recommended are just a few basic facts or a few basic components. Evidence-based provider or prescriber training. So those that are writing the prescriptions and ordering the cultures need to know. Use of a standardized communication form. And I've got an example of one of those coming up. Resident and family education, ongoing monitoring and feedback, primarily of antibiotic use, but it could be other components. And then again, those monthly QI meetings to discuss everything that's going on and challenges. But overall, leadership commitment is absolutely crucial to a successful program. You need to have leadership take this and support it. Next slide. I like to include this one. It's asymptomatic bacteriuria and treatment, in air quotes. Many of you probably already know asymptomatic, so there's no symptoms, no signs or symptoms, bacteriuria, bacteria in the urine. That's not to be treated, except into situations of pregnant women, and also if there's going to be surgical procedures on the urinary tract structures and there's bacteria, it's recommended that those are treated. So primarily you're not going to have those in your facility. But this was a study that was done at University of Michigan Medicine Hospital. So not nursing home based, hospital based, found that inappropriate utilization of urine cultures was quite high. And this was back in, I want to say 2015 it was published, so probably 2013, I think this one was conducted. And it was patients being followed by a hospitalist. So a hospitalist, they don't have the ability to really know the patient outside of the hospitalization. They don't do follow-up, so they don't know them quite as well. They're on the hospitalist service. 210 patients had urine cultures ordered many times at the time of admission. So if they're coming through the emergency department, they're having them done. 54% did not have an appropriate reason for obtaining that culture. So that's not necessarily on the hospital list or, physicians that are seeing the patient after their admission, but room for opportunity there. And of those negative 45% of the negative cultures, so of those that were collected, almost half of them were on antibiotics at the time of culture, another issue. So overall, what they found was that treatment of asymptomatic bacteria was going on quite a bit. Almost all of those patients that almost all of them with asymptomatic bacteriuria were treated with antimicrobials, which leads to, if we're breaking it down by day, way too many days of excessive antibiotic therapy. So room for opportunity at the hospital level, emergency department level, and we know that that just carries on as they move into post-acute care. Next slide. Case scenario that I also presented to our APIC group to get them to kind of think about what kind of situations might occur in nursing homes. And as I've been going throughout the state, visiting nursing homes and doing site visits and education, I hear about this quite a bit, although it seems to have been getting better over the last couple of years. So I'd like to hear from you, either you can break in now or hold it on till later. An elderly patient with a history of recurrent UTIs, again in air quotes, complains of symptoms similar to prior episodes. What are the symptoms? Well, the symptoms are cloudy urine, it smells bad, no dysuria, no suprapubic pain, no flank pain, no fever, and the resident daughter who's there visiting says this is how it always starts like this. And once she gets her antibiotics, then she'll be fine. And a UA and a culture are sent, and they start empiric antibiotics. So is this what you would expect to happen at your facility, or have maybe in the past and things have changed? And how did you get that to change? Monitor increased fluids. Yes, absolutely. One of the things that and we'll just continue to talk a little bit about this since we're on the slide, and I've got somebody that chimed in. Thank you for that. Cloudy urine that smells bad. What are the primary reasons for that? Is there a correlation with infection? There actually isn't. Most of the times it's poor hydration. It is medication. Medications can definitely alter your urine smell, how it appears. And foods, right? We know for a fact that food and drink can affect your urine as well. Continued need for facility reminders to avoid empiric use. Absolutely, totally agree, Kelly. Thank you. You can go to the next slide. And I'd like to include this study as well. So this was part of a much larger study, actually an intervention that was called Kick Caudy. And this was part of a baseline survey, and it was to evaluate knowledge gaps and biases. And it didn't just go out to nurses and nurse assistants like you see on the slide here. It also had a big focus on prescribers, not just physicians, but residents, nurse practitioners, and also not shown on the slide is that identified, I think, a 78% correct response rate for prescribers, that they were prescribing correctly. All right, so then that information was taken and made into a learning module to improve prescribing. But this one I thought was interesting because it looks directly at nurses and nurse assistants. And this came from 4 VA hospitals across the country. And not just acute care, but also their long-term care component, their CLCs staff. And you'll see that CNAs are represented in blue, and then RNs are in green. Just to kind of see, like, what do you think, what would trigger you to be concerned that this resident may have an infection and that a urine culture would be warranted? Change in urine color, foul smelling urine was really quite high for the CNAs, and also cloudy urine. Nurses also had a pretty high response rate for those changes in urine color and foul smelling and cloudy urine aspects. We know that a fever can definitely be caused from a UTI, but it's recommended that other sources of infection are considered as well, and not to automatically jump to that urine culture. So just kind of an interesting study that was published. Next slide. What interventions work? There was a systematic review. So they did a literature search, what's actually out there, what's been done, what works. And they pulled all that information together and found that most interventions were multifaceted. So that's great that you're pulling in all different ways and methods to be able to actually effectively implement antimicrobial stewardship. But it can make it a little difficult when you want to narrow down what is actually working, right? So they found that 13 out of 16 had more than one, and the median was actually 4 different strategies. What absolutely worked were educational meetings and materials. Education could be for the physicians, the prescribers, the pharmacists that are involved in the work, also materials and guidelines that were distributed to a multitude of different healthcare workers within the facilities. I found that interventions were associated with a 13% reduction in antibiotic use overall. So it did move the needle. But overall, that leadership commitment and support, again, always circling back to leadership, was the most effective component in the effectiveness of an antimicrobial stewardship program. Next slide. Our University of Michigan project team, we've been working on infection prevention, all different components of that. We did do some work on antibiotic stewardship, put together some materials. I encourage you to take a look at our PRISM resources page, which is highlighted down at the bottom of the page. This infographic on the right-hand side was developed by one of our MPH student interns during the summer, who had a really great interest in antimicrobial stewardship and prescribing patterns and how we can potentially impact that. Next slide. Just another way to reinforce best practices on another MPH student, Trent, I have him listed as getting credit down at the bottom. He primarily put this together, hopefully for use for those nursing homes, for the direct care workers. So I just wanted to highlight in the middle of this flow chart, it mentions to collect urine culture by clean catch or straight cast. And I've heard from many nursing homes that that is definitely an opportunity. I can say from the hospital side, opportunities abundant. I think people forget of the importance of educating patients or assisting them in doing an actual clean catch urine specimen collection, because we know that contamination is huge. Oftentimes labs can identify if it's like grossly contaminated, but we definitely want to get the most accurate specimen possible. And if straight casts are warranted, then definitely to go that route. But this is available on our website as well. I think a question just popped up. Hang on one second. Following McGear criteria. Are you talking about in reference to this slide? It is mentioned down at the bottom. So revised McGear's is surveillance criteria, absolutely. And then we also mentioned low minimum criteria, because we know that prescribers, providers are really going to be looking at those guidelines to guide clinical treatment, and that would definitely be appropriate. Next slide. Another piece of this is engaging residents and family or visitors, loved ones. What does this mean? As part of one of our QI initiatives at University of Michigan, we had a very engaged nursing home in Detroit that was part of one of our initiatives. They felt that they could put together a QI project that directly addressed asymptomatic bacteriuria and inappropriate urine culturing, as well as antibiotic prescribing. So what they decided to do is they had two pieces to this intervention. For staff, they improved their education. They did an educational checklist, and they also provided a very brief, simple to understand scripting that could be used for residents and their families, making sure that the residents and families knew that their concerns were being addressed, and depending on whether it was a CNA or a nurse, who they would be escalating their concerns up to, and for nursing, for them to be aware that antibiotics were not the go-to, and that there were guidelines set in place at this facility to ensure that testing and prescribing was only being done when necessary, in conjunction with working with the physicians. So this was for staffing. It was done at hire and also at periodic in-services to make sure that they were aware. And going back to that graph that I highlighted on CNA and nurse understanding of when urine culture should be done, they actually use that information to guide their intervention. They also put together, the nursing home put out a very simple handout for residents and families that addressed those exact concerns. And it's shown on the right. We opened it up and it had a couple of pictures and just some bullet points. And it talked about the risks of antibiotics when they're not necessary. This was shared at admission, change of condition, and then during their care conferences. Next slide. You may have seen this in the past. It's a situation, background, assessment, and recommendation, a piece of the intervention when it comes to communication, making sure that you've got all of, or nursing primarily, has all of their information pulled together prior to contacting the physician or doing a follow-up, to make sure that we've got all of the necessary information to help them in that decision-making on testing and treatment. One of the nursing homes that we've worked with really liked this and had already been aware of it, but once we talked to them a little bit more, they pulled that into their electronic medical record and made this something very similar as an online or an electronic component. Next slide. And again, this is mainly directed to those that are making the decision to test and treat, and is part of a larger intervention that's in the publication by Tama et al. And it's listed in my resources page. But this is just one of the very simple ways of conveying those questions that prescribers should be asking themselves. And within the publication, they've got other types of resources and materials and tools that's more directed at those that are making the decision to test and treat. Next slide. This one is also from my friend, Dr. Patel, something that she experienced and she decided to write up. You can click series of unfortunate events, nursing home edition. So an adult patient, resident, long-term care loses her glasses. They become more confused. A urinalysis was ordered. Plus, let's start them on Cipro because it happened to be on a weekend in the middle of the night. Possibly somebody who's not familiar with this resident, along with nursing staff that's not familiar with this resident. What can hurt if we just start them on an antibiotic? Next, click. Yes, places to intervene. Become nauseated. Very, very common with Cipro. Next, they become dehydrated. Became dehydrated quickly because this resident is 90 pounds. She's advanced age. She can't even look at a glass of water without feeling nauseous. The dehydration causes some low blood pressure. Next, click. And she goes to the emergency room. And speaking from experience, we'll go ahead and test anybody's urine that rolls in the door, especially nursing home residents. That was performed, probably not done clean catch style. And they started her on Rocephin, ceftriaxone. Next. And IV fluids, which improved. She improved with probably related to that dehydration. She's feeling better, no longer has that offensive Cipro in her system, but it may appear that she improved due to the antibiotics, right? Next click. However, that urine culture returned a resistant Klebsiella. And there's always a big concern and a drive to treat that, both the hospital side, nursing home side, regardless. And a lot of hesitation from those providers to not do anything. Next. But again, look back, there's no signs and symptoms of an actual UTI. Prescribed her cefepime, which is a higher risk antibiotic, more adverse effects seen with this. And next click, last click, we end in CETA. So seems like there's a big cascade of things that no, would that really happen? But according to Dr. Patel, this has happened more than one time, not necessarily with the losing the glasses situation, but just so many different opportunities to potentially intervene. Next slide. Again, as it relates to antimicrobial stewardship for potential UTIs, as we know that's a big reason that nursing home residents are being prescribed antibiotics. So narrowing down in that category, ordering urine cultures. Want to make sure that there's an algorithm or some other method that's been looked at by your prescribers, your providers at your facility, and that nursing staff is fully aware of to better understand when a culture is actually warranted. the choice of antimicrobials, having a good partnership with your pharmacist. There has been some situations where pharmacist needs to be contacted before those risky fluoroquinolones can be prescribed. I don't know if that's something that's being done on the nursing home side, but definitely at the hospital side, that's one of the opportunities that's been identified and acted on. Review of antimicrobial use, definitely understanding your trends. Are there certain situations that you're seeing more antibiotics prescribed for certain prescribers? Are they prescribing higher risk antibiotics? And then gathering the data to look specifically at the duration of antimicrobial use. And that's something that infectious disease physicians, pharmacists probably have more of an opportunity to weigh in on, especially with expertise related to antimicrobial stewardship. Next slide. So who could be an antimicrobial steward? All of us, right? But at the very top, administration, because again, support is key. Your medical director we really need that support at the top. And an infection preventionist, hopefully your facility has an IP that is knowledgeable or can learn about different strategies. Nursing, because nobody spends more time with the patient. And again, circling back, administration, that's doubly important. Next slide. Who's part of the team? Again, it's a core component of an infection prevention and control program in nursing homes. It's only gotten to be more essential that you've got a good one set up, and it's probably going to become even greater. There's going to be greater scrutiny when it comes to evaluating what kind of program you have and where you have room to improve. Know that the facility IP is many times responsible for managing and coordinating the team. It probably might look different at your facility, but there's a lot of pieces to this besides just pulling people together for a meeting. Identifying, informing, educating, monitoring, and then looking at process and outcome surveillance when it comes to antibiotic use. Think about who leads your antibiotic stewardship team. I know at the hospital side, ideally it was someone, an IP that had a great interest in antimicrobial stewardship, as well as a pharmacist. But I'd be curious to know who is leading your team. Next slide. And again, being aware that whether it's your IP that's leading the team or really anyone else, it definitely takes dedicated time. It takes support and resources to be able to get something like this up, to be able to keep the momentum going, to be able to identify issues as they pop up, and to create an action plan on how to improve. Next slide. So what else is being done? I will say, as Dr. Bagdasarian mentioned in her quote, have things dropped off a little bit during COVID? I think that they probably have, but there is going to be greater attention paid to these. Dr. Lona Modi wrote, "Can infection prevention programs in hospitals and nursing facilities be integrated?" That led to some of the work that we've done in the last few years to try to improve those relationships between nursing homes and their local hospitals. And then also in this other paper that was published, I think it's really important to note that which this study looked at characterizing antibiotic exposure across the healthcare continuum. So what's happening in the hospital absolutely impacts what's happening in post-acute care settings, both at the resident level and in their room. It's affecting the physical components and what the facility's colonization level of the resident's room, shared areas overall. So much more work to be done, but recognizing partnerships that could definitely make an impact. Next slide. And just to mention, nursing homes probably don't have much of, unless you worked in a hospital, knowledge of Joint Commission. Joint Commission accredits like 99% of hospitals in the US. They are coming out with, as of this year, January 1st, 12 new and updated requirements. They're really hammering home a lot of components and interventions that can improve hospital antimicrobial stewardship programs. So more to come on that, but hopefully that will affect those in post-acute care settings as well. Next slide. I want to close out on a study that our team did, again, just to remind hospitals, nursing homes, that there's so much interconnectedness, I guess, throughout healthcare settings. This was a study that was done by our team. They looked at when residents were admitted to a post-acute care setting, what was on their hands, what was growing, and they wanted to see what was colonized on their hands on admission. And then take a look at it during follow-up visits. And what were their findings was that 24%, almost a quarter, had at least one multi-drug resistant organism on their hands at admission. And we know that there's opportunities to encourage hand hygiene for, obviously, healthcare workers, but also residents and our patients. Next slide. And this breaks it down just a little bit more. Findings where the hospitals are routing MDROs into post-acute care, but they increase during the post-acute care stay. This is just looking at their hands, right? But we know that that affects more than just the hands during their admission. You can hit the next click. And that looks at all of the different 6 facilities throughout Southeast Michigan that were included in this particular project. Next slide. So circling back to that conceptual model, what's your biggest challenge? And what do you want to focus on? Can be a lot to think about, but focus on one thing, if there's more than one thing that your facility really needs to improve upon, and go from there. Next slide. A little bit about our project team at University of Michigan. We've got a lot of different projects or partnerships. We work a lot with the VA hospitals, not just in Ann Arbor, but Detroit and Cleveland. Done and published quite a bit on MDROs throughout Michigan. And we continue to do more. We did also work on the ECHO, well, ECHO, we called it M for University of Michigan, that I know that Kelsey was a part of, to engage nursing homes and infection prevention strategies. Next slide. And if you're interested, you can find all of our publications, including some that I talked about, and other information on our project website. Next slide. And that does it for me. Happy to have any questions, comments. Please share your feedback. Anything that I didn't cover that you really wish was covered, or that you'd like more information about. And thanks for listening.
Karen, thank you so much for your wonderful presentation. I think this at least gave me a lot to think about and sort of walk through as we're considering, what does this process look like? Maybe what are our challenges? What things do we need to do differently, et cetera? I do see a comment here in chat from Heidi. It doesn't appear that clinical monitoring was addressed on today's call, rather than initiating a UA right away when having 1 to 2 symptoms. So just a comment there, Karen, but I don't know if you want to respond to that.
Yeah, no, I didn't include that. We do have some tools if you're looking for guidelines, or you can just go ahead and ask if you've got a specific question, you can go ahead and ask that. On our the website, the University of Michigan Prison website, we've had many discussions because the primary focus of that particular work was UTI, CAUTI prevention, but also making sure that prescribing was done appropriately. So we've got some materials on our website that might be useful if you're looking for something specific. One thing that I didn't mention also was we also recently for that project included the MDHHS team that shared different spreadsheets on antibiotic use and tracking, but also there was a way that they were able to pull that into creating data charts and different tables that was useful to be able to share with your facility at your QI meetings. And some of that stuff was really good. I know a lot of facilities already have something like that. If not all of you have something like that that you're using to track and trend use. But sometimes it's nice to be able to see what else is out there, and maybe it includes something that you wish that your current one included that could be able to be used in different ways and expanded ways. Yeah, so hopefully the website offers a little bit more. You can always, message me offline if you'd like, and I can definitely help try to get you what you're looking for.
Karen, I'm guessing that most nursing homes use the McGreer's criteria for deciding on what to do next, right? Should they reach out to the practitioner to get to prescribe an antibiotic, or should you monitor, so on and so forth? There's also though the Loeb's criteria. Are they? And I'm not very familiar with the Loeb's at all. Are they essentially the same, or does a physician using Loeb's and a nursing home using McGreer's, does there cause any conflict, or do they both kind of flow fairly the same?
Well, I've never worked in a nursing home to actually gather how that, if they conflict at all. I can tell you by looking at those, there's not a ton. The challenges that I see, or that I've heard about, is the surveillance definition, when you're actually trying to make that definition when you're counting something, I guess, when you're reporting out your number of UTIs or CAUTIs for the month that way. I don't know how much, and maybe some of our nursing home representatives can chime in, how much they're looking at Loeb's criteria, like nursing staff is looking at that to help them determine, because I think that primarily they're looking at they're looking at McGreer's, which again are very similar.
Thank you.
All right, well, I know we have just a couple minutes left, so if there are any additional questions, please feel free to add them to the chat and we can pitch those over to Karen. Kim, if you want to just advance, I did include a slide here almost all the way at the end of the deck, with just a handful of our upcoming sessions. We want to try to provide this to you in advance so you know kind of what's on the docket, and so you can make sure you have the right people or team members on the call each session. So our next session, which will be 2 weeks, will be QAPI and root cause analysis. Then in February, we'll be talking about how to address challenging resident behaviors as well as fit testing. And then kicking off our program for March, we will be talking about a campaign that we've recently launched at Superior Health called Shine a Light on Stigma. So those will be our next 4 sessions that are on the slate. As I mentioned at the beginning of the call, if there's any other topics you want us to cover, please let us know. We're happy to add those as we continue to build out what the rest of our 2023 schedule looks like. So before we close out, are there any last comments, questions? And I do see Jerry put the link in chat for our evaluation survey. So if you can just take a couple minutes to open that up and give us feedback before you log off, we will greatly appreciate it. And with that, I will go ahead and close our call for today. Karen, thank you again so much for joining us and for all of your information that you provided today.